Hello, this is Dr. Amin Marashi, retina specialist in Marashi Eye Clinic in Aleppo, Syria. I am presenting the course of Structural EnFace OCT, and in this presentation I will present the structural EnFace OCT findings in retinal vascular diseases. In diabetic macular edema, the fundus image or macular topography may give the impression that the macular edema is not involving the center. The IPL-INL slab will show hyperreflective cystic changes and may show hyperreflective dots resembling hard exudates. In contrast to macular topography, the EnFace OCT can give the edema's accurate location and give a pan view to changes in intraretinal cysts and hard exudates. Please note the blink artifact. This is an example showing non-central diabetic macular edema. The IPL-INL slab gives a pan view of cystic distribution, which appear as hyporeflective cysts, and the hard exudates appear hyperreflective, which can help for focal grid laser treatment as a guide. When diabetic macular edema exhibit intraretinal cystoid changes, the hyporeflective cystic changes may resemble a honeycomb configuration. Other DME cases may appear with only hyporeflective cystic changes, depending on the Henle fiber layer structure. The RPE slab may show projection artifact from the hard exudate in the form of hyporeflective dots. Please note the motion artifact. In segmented EnFace slabs, the outer plexiform, the cystic changes will appear more polygonal and irregular. However, microaneurysms will appear as hyper-reflective with medium reflectivity, and this can confirm by fluorescein angiography. When cysts have hyper-reflective content, the IPL-INL slab on EnFace OCT will show cysts that appear hyperreflective compared to cysts with clear content. In cases of diabetic macular edema, the IPL-INL slab can help to assess connectivity integrity of the inner retinal layers, which may help in predicting visual prognosis. The IPL-INL slab can be used to follow up patients with diabetic macular edema pre and post treatment to assess the treatment's efficacy. It shows irresolved cystic changes, as shown in this IPL-INL slab post-treatment of the previous case. IPL-INL slab or segmented INL-OPL slab can be useful in comparing structural OCT and OCT angiography that shows correlation between vascular structures, blood flow, and retinal tissue structural changes. This will help to understand the pathological changes related to diabetic macular edema and diabetic retinopathy, such as differentiating between ischemic changes and cystoid macular edema in cases that foveal avascular zone appears enlarged on OCT angiography. The ILM slab will show any vitromacular changes and may identify the size and distribution of vitromacular traction or epiretinal membrane, which appears as a hyperreflective retinal falls showing the area of epiretinal membrane adhesion. In contrast, the IPL-INL slab will show hyperreflective cystic changes and hard exudates if they existed. Please note the blink artifact. A large cotton wool spot may show an area of discrete increased hyperreflectivity in the ILM slab, while the induced projection artifact will be shown on RPE slab. However, the IPL-INL slab can reveal any coexisting macular edema which appears as cystic changes or hard exudate in the form of hyperreflective dots. Please note the motion artifact. In cases of proliferative diabetic retinopathy, the ILM slab will show a hyperreflective membrane corresponding to the fibrovascular tissue. Please note the segmentation artifact. In cases, the RPE slab will show a projection artifact resembling of the neovascular network. In some cases, the ILM slab may help recognize the fibrotic changes which may depict neovascularization. The structural EnFace OCT shows diabetic retinopathy changes in different retinal layers. As in this case of proliferative diabetic retinopathy, the ILM slab may identify the fibrovascular tissue in PDR cases. In contrast, the IPL slab can rule out hyporeflective cystic changes that depict the presence of diabetic macular edema, and some cases can show neovascular changes. The RPE and choroidal slab may show only laser scars in cases treated previously with PRP, and the RPE slab may show the neovascular network's projection artifact. Areas of retinal non-perfusion will appear in the IPL slab as hyporeflective areas divided by more hyperreflective retinal vessels. In cases of branch retinal vein occlusion, the IPL slab will appear irregular, hyperreflective patches in the involved area of the occlusion in contrast to uninvolved area, and this due to intraretinal hemorrhages. This slab will show cystic changes in cases associated with macular edema. The RPE slab will show a hyporeflective lesion due to shadowing from intraretinal hemorrhages. Please note the blink artifact. The structural EnFace OCT on the IPL INL slab can help to follow up resolution of cystic changes post-treatment, as shown in this IPL INL EnFace slab for the same patient of the previous case but post-treatment. In the case of central retinal vein occlusion, the IPL slab will appear hyperreflective throughout the slab, covering all areas that contain hemorrhages, along with hyperreflective cystic formation in cases associated with macular edema. The RPE slab will appear more hyperreflective than usual due to shadowing from intraretinal hemorrhages. Please note the blink artifact. However, the adjusted segmentation, which involve ILM to OPL layers, will show an increased reflectivity of the slab due to increased reflectivity of inner retinal layers in acute cases. In the case of retinal vein occlusion with non-perfusion areas will appear in IPL slab as hyperreflective pockets bordered with major retinal vessels. EnFace OCT can sometimes reveal signals from basement membrane remnants of occluded vessels not found in OCT angiography. However, in cases presented with neovascularization, the ILM slab will show hyperreflective membrane while the IPL slab will show hyperreflective pockets bordered with major retinal vessels. Please note the leaking neovascularization on the disc and hyperreflective cystic changes in the area of associated macular edema. As in diabetic macular edema, cases presented with vitreomacular abnormalities, the ILM slab will show hyperreflective faults. In cases of branch retinal artery occlusion, the IPL slab will appear more hyperreflective in the involved area of the occlusion, in contrast to the uninvolved area, and this simulates the hyperreflectivity of inner retinal layers in the OCT cross-section. Please note the blink artifact. The RPE slab will show revert color of the INL IPL slab. For example, the involved area that appears hyperreflective in the IPL INL slab in the RPE slab will appear hyperreflective and vice versa. This is due to projection artifacts. Please note the blink artifact. In central retinal artery occlusion, the IPL slab will appear hyperreflective throughout the slab, covering all areas involved in the occlusion. However, if the retinal occlusion spares the cilioretinal artery, then the spared area will appear hyporeflective. In cases which are severe, the entire slab will appear hyperreflective with high contrast, even affecting the underlying slabs. Hence, the RP slab will appear more hyporeflective than usual due to the projection artifact. As mentioned above, in severe cases, the RPE slab will appear more hyperreflective than usual. In cases of hemorrhagic retinal artery microaneurysm, the ILM slab will appear hyperreflective in the involved area of the hemorrhage, and it depends on the level and intensity of bleeding. The IPLINL slab will appear hyperreflective in the involved area of hemorrhage and depends on the level and intensity of bleeding, as some cases will show increased reflectivity depending on the area of segmentation and reflectivity induced by the hemorrhage. The RPE and choroidal slab will show hyperreflectivity due to the shadowing effect from the overlying hemorrhage. Please note the segmentation artifact due to a defect in segmentation line. Please note the blink artifact. In exudative retinal artery microaneurysm, the segmented EnFace slab may show the macroaneurysm in the form of hyporeflective lesion. The subretinal fluids may appear as hyporeflective pockets, but the reflectivity depends on the subretinal fluid content. The IPLINL slab may appear hyperreflective dots corresponding to the area of intraretinal hard exudates clusters, while intraretinal cystic changes will appear hyporeflective cysts. The RPE slab will show areas of hyperreflectivity that correspond to subretinal exudation. In contrast, the areas of intraretinal hard exudates will appear as hyporeflective due to projection artifact. Please note segmentation and blink artifacts. The choroidal slab will show projection artifacts from macular edema, which will appear hyporeflective. Some cases may be presented with hyperreflective patches due to segmental artifact, and the segmentation contour deviates toward the subretinal exudation. Thank you for listening. Please visit the Retinal Assistant module at amretina.com for more online courses and guidelines.